Good morning, everybody. I would like to thank Christine Whitmore for the invitation. Just a short question. How many physiotherapists are in the room? Okay. How many urologists? And how many gynae? Good. Excellent. My talk is an overview on the chronic pelvic pain and central sensitization. This is my disclosure. Looking at the pelvic anatomy, pelvic anatomy is very complex because there are a lot of organs, a lot of muscle apparatus, and a very, very complex neurologic network that create the modulation for deep pelvis as well in the periphery. Looking at the pelvic pain, we need to distinguish between acute versus chronic pelvic pain. And there are some different characteristics because in the acute phase is generally known, duration is short, well characterized, and with the treatment approach with underlying disease, while in the chronic phase is often unknown, persists after 3 months with underlying disease and pain disorders. Looking at the international classification by the IASP, the International Association for the Study of Pain, chronic pelvic pain is defined as a non-malignant pain perceived in structures related to the pelvis of either men and women. The pain must be continuous, or recurrent for at least 6 months. But chronic pelvic pain is a gender disease because the majority of patients are female population, in the female population. The definition of the Royal College is an intermittent or constant pain in the lower abdomen, at least a 6-month duration, not occurring exclusively with menstruation or intercourse, not associated with pregnancy. And from the American College, non-clinical pain, at least a 6 months duration, appears in the locations such as the pelvis, anterior abdominal wall, lower back, buttock, and that is serious enough to cause disability or lead to medical care. Which are the characteristics of visceral pain? Diffuse, difficult to localize. It's possible to impede that slide continuously. Dull, cramps associated with autonomic reflexes as nausea, sweating, increase in blood pressure. Looking at the prevalence, go from 5 to 7.7 to 43%. Imagine, with repeated absence from work until 32%, decreased fertility up to 64%, and the cost is unbelievable, 65 billion per year in the United States, billion per year. The medication consumption of gynecological surgery of women with pelvic pain are 4 times higher, and only 40% of women consult a physician with the improper diagnosis to 20 to 70% of cases. In primary case offices, 12 of women reported CPP currently, and 33 related to a past history of chronic pelvic pain, and 12 of women had pelvic pain more than 5 days for a month. Which is the magnitude, another report. 14.7 of women CPP for 3 months. That means 9 million women in US, 20% had pelvic pain more than 1 year, and account for 10% of referral to OBGYN, 40% to laparoscopy, and 18% to hysterectomy. The prevalence as health-related quality of life, because 16 reported pelvic pain, 11 limited home activity, 17 took medication, and 4% missing 1 day a month. This is the quality of life with the effect of chronic pelvic pain. If we look at the physical functioning and psychological morbidity, you see that, as very well known, that a patient with pelvic pain has depression, anxiety, anger, loss of self-esteem, with societal consequences, with healthcare costs, disability, and lost work days. One of the causes is myofascial trigger points that can be elicited during a physical examination during all the pelvic cavity on the levator ani muscle, coccygeus, and pyramidal muscle. And I would like to stress your attention to a very recent theory proposed by Papa Petros, that is a urogynecologist that naturalized in Australia, coming from Greece. He proposed the integral theory for the pelvic floor, that the pelvic floor is intended as a balanced, integrated, dynamic, and synergistic musculoelastic system, acts on the pelvic organs, ensuring their shape and function. And he postulated the hypothesis that the posterior ligament in women, the posterior uterosacral ligament, if they are relaxed, they can cause pelvic pain. This is one possibility. I don't know if it's really true, but according to his theory, he proposed to stretch with a simple surgical procedure the two uterosacral ligament to recover and to release the patient from pain. Which are the CPP syndrome? They affect all the aspects of the pelvis, the urinary tract, genital, pain in female and in male, gastrointestinal, musculoskeletal, neuropathic, psychological, and sexual pain. Looking at the apparatus, we have, referring to the urological apparatus, the bladder pain syndrome, interstitial cystitis, the urethral pain, penile pain, prostate, scrotal, as well gynecological, the classical pelvic endometriosis, or vaginal or vulval pain, the classical vulvodynia. All also in the anorectal, as neurological, as muscular, there are several aspects of pelvic pain syndromes. One of the important phenomenon is the pelvic cross-organ sensitization. That means one organ speaks to the other, with you see an integrated perspective. So the bladder, for instance, with the afferents go to the dorsal horn, and there is a connection with the colon. And the mast cell, they play a pivotal role in the cross-organ sensitization. That is a transmission of noxious stimuli from a diseased pelvic organ to an adjacent normal structure, with the axion convergence of antidromic propagation to adjacent organ, and they arrive to the brain. This is a classical dorsal horn with the C fiber and A delta fiber in a normal, as well in a damaged situation in which there is a transmission anomalies. But in this architectural, there are also another actor. The other actor is microglia. The microglia is the one of the cells that are present in the spinal cord, and there is a neuropathic pain with a central neuroinflammation. So the pelvic pain, the chronic pelvic pain, through the inflammation of the microglia, they arrive to a central brain. So there is an interaction between the immune and nervous system in pain, with the two important cells, the mast cell and the microglia. And so we arrive from the periphery with the A delta and C fiber, with the first neuron, with the second neuron through the spinothalamic tract. They arrive to the brain with the cortex, with the pain perception, with memory and insight, with the limbic system, with the emotional and psychoaffective aspect, and the hypothalamus, with the brain global activation that create a lot of anxiety. And this is the classical phenomenon of the pilgrimage, and the patient will go from gynecologist, dermatologist, urologist, neurologist, psychiatric. This is classical pilgrimage of a patient with CPP. But there is another important aspect looking at the chronic pelvic pain, the synaptic plasticity, because there is the phenomenon of the input, the afferent input from the periphery, that during the time they arrive to the central nervous system. And in 1983 and 1984, Wolf and Wall, they discovered the central sensitization level of the spinal cord due to long-term effect of the repeated nociceptive afferent inputs. Why pain memory and synaptic plasticity? Because early warning system to avoid potentially dangerous situations, allowing to keep in mind this hazard, and the sensitization alike quick escape responses through the reduction of the threshold of activation. And this is, again, you see from the dorsal horn, they arrive until, with the spinal thalamic tract, they arrive until the brain system through a lot of neuromediator, opioid with the opioid receptor, glutamate receptor, GABA receptor, through the sodium and calcium channel. And this, the arriving with the descending tract and ascending tract to the cingulate cortex and the sensory cortex with the system we saw before that is related also, you see, to the emotional instability. This is one of the aspect, with reflected to the behavioral attitude of the patient due to visceral and reflected system. Now there are clear evidence that there is a neuroinflammation and comorbidity of pain and depression. You see that the patient has chronic pelvic pain, therefore has depression. No, there is also a pathophysiological aspect due to mast cell with the peripheral sensitization and the microglia with the central sensitization in neuropathic pain. So there is the central sensitivity syndrome with, you see, insomnia, sleep disorder, chronic fatigue syndrome, fibromyalgia, interstitial cystitis, and so on. There are a lot of but there are some objective measures of central sensitivity syndrome. One is this to effective evaluation among brain regions with slow temporal summation of C-fiber evoked pain in fibromyalgia, as well as recently has been discovered abnormalities in female with BPS-IC in brain-wide matter on MRI approach. This is a study we did recently on a patient with bladder pain syndrome, chronic pain, and the aim of the study was to see the central sensitization in bladder pain syndrome, chronic pelvic pain, and the correlation with other related disease. 58 women recruited from 2014 to 2016, 4 women and 4 men and 55 women, submitted to central sensitization inventory, that is a specific questionnaire, and the onset of symptoms you see is 33 years. 33 years. You can imagine a patient after 33 years of pelvic pain. And the mean sensitization index was 69, while this is the classical questionnaire we gave, and you see the cutoff is only 28.9, and our patient was 69. I don't want to stress again, but these are the data we got from the study. The last one, the cutoff was that the central sensitization is obtained after 1.5 years. That means the strong message: if a patient, if a patient has a problem of chronic pelvic pain, please treat immediately, because if not, the pain can become centralized, and there is a big problem later on. So in conclusion, patients with long-lasting pelvic pain show increased level of central sensitization, and they develop after 1.5 years of pain onset, increasing number of other diseases associated to central sensitization over time, worsening of overactive bladder syndrome, and use of drugs. These results suggest a predisposing factor to abnormal central sensitization. And this result is consistent with the most recent MRI studies that have shown an alteration of brain connectivity. That means that a simple syndrome, the chronic pelvic pain, can become physically, because there is a real changing, for instance, on the tissue, for instance, on the white matter of the brain. So, the final take-home message: pelvic pain is not only physiological or psychological. Yes, obviously there are a strong component of psychological aspect, but the chronic pelvic pain can be treated, and please don't forget to look for it. Thank you.